Hello everyone. There's going to be a recording from the very beginning of my research. I haven't even entered the search term yet. And while I do this today, I do anticipate some disturbance as I do on other days as well. It's the time when the local businesses are already active, so you might hear, like on other days, one or two of their employees saying something, doing something, or any of those sounds. So it can happen at any point in time. I'm just letting you know. Okay, the search, which I actually did begin last night. I have often heard from a set of doctors, and especially from Dr. Peter McCullough, about early treatment for COVID-19. Now, I've heard some doctors say that there is no protocol for early treatment. There is no early treatment for COVID-19. And I came across this particular statement and this sentiment on Twitter. Not so much on YouTube. Excuse me. I do go through a lot of information. Habitually, I read a lot, I research a lot. A lot of the times, to get new information, I find that watching a video by an instructor, by a capable instructor, who could be a doctor, an engineer, an author, musician, anything that I'm researching. I find that watching a video is, in many cases, preferable to reading it in a magazine or reading it in a book. So this is a good medium. And I'm trying to make use of that as well. In my videos, you will always see the focus is on the material. It's not on me. I am simply a medium. The message is the important thing. Excuse me. So let's begin this research. Let's type early. You see, as soon as I typed early, it already picked up what I had searched for earlier, early treatment for COVID-19. So I'm going to click on that. Let me also tell you now that if there is a disturbance which is especially bad, then I would let you know and mute the mic. So when I mute the mic, everything will go completely silent. Let me give you an example, in fact. I'm going to mute the mic in 1, 2, 3. So I muted the mic for a few seconds, and as you could see, it went quiet, as it should. So today, as I entered the search, early treatment for COVID-19, I'm not using some special facility that is not available to anyone else. I haven't gone to a site yet, because it's possible that there are so many sites and you've never been to that site. I'm simply on a search engine on Microsoft Bing, and you could be on some other search engine. And the results would vary, of course, but a lot of these sources and their rankings would be pretty similar. So when I entered early treatment for COVID-19 and I'm in all results, what do I find? Very neatly organized by Microsoft. So TGA approves new COVID-19 treatment. Over60.com.au. This is from Australia. And these are news sources. How can I get Paxlovid, the COVID-19 pill? Access to COVID-19 treatments remains a challenge. Demand for antibody treatment for COVID-19 rises. KRGV 1 hour ago. Mumbai, Pawar, he's a minister. He's in politics. Tests COVID-19 positive. PM calls him for early recovery. So he's an elderly man. His profession aside, that has nothing to do with his being positive. Excuse me, it's a cold day today. You want to see what the temperature is like here in New Delhi? I think it'll show. It says, good afternoon, SK, 12 degrees Celsius. That's cold. How much is 12 degrees in Fahrenheit? 12 degrees Celsius to Fahrenheit, 53.6. So it's 53.6 degrees Fahrenheit or 12 degrees Celsius. So by my estimation, that's the temperature outside. But inside as well, I do feel that it's pretty much that outside. And as I'm looking outside, we don't have bright sunshine today. It was raining for a few days, a couple of days actually. And we had some sunshine yesterday, but again today, it's overcast, it's cloudy, and we don't have bright sunshine. When that happens, we'll get some warmth. So I'm ignoring, coming back to the research, I'm ignoring those top results which are from the news. And I'm just looking at, as you can see, the links have changed color to purple. The links I have not visited are still blue. So this one is blue. But the links I did visit last night, I believe, those have changed color. So let's open this. I'll open this in a new tab and I'll keep this main search page open. So I'm going to open this. I'm going to open this. And I'm going to open this. And Harvard Health. And Science News. I'm opening the same links which I did yesterday also. And sometimes it mentions how long it takes to read an article. Like this one, it says estimated reading time 7 minutes. And that's good. That's a little touch which makes a difference. Before you open an article, you know how long it is going to take. This is from the NIH, and I'm going to open this too. So 1, 2, 3, 4, 5, 6 tabs already opened. This article I looked at yesterday, and I found this to be interesting. I'm already telling you this is about melatonin. And this article has a lot of references. When I stop recording, I'm going to keep all these tabs open, and the link for each one of these articles is going to be in the video description. That I would do for myself as well. In case I ever go back to this article or this video, I'd like to look through the articles that I consulted. And as you can see, I started the search in front of you, and I'm just proceeding from there. The results have actually changed in sequence since last night. I remember that. Last night, the results were a bit different. So these are dynamic. It could change, of course, in a month from now, if you look at it, or even tomorrow, some changes would have happened. Could happen. Let's open one more article. NEJM, New England Journal of Medicine. And treatments for coronavirus, nhs.uk. So there would be some repetition. There could be multiple sources saying the same thing. It's quite possible. So let's just go through the results. What I'll do before going into some specific information is that I'll look at the article all the way to its end. Okay, here the references are mentioned, so it's already at the end. And as I was expecting, number one, reference McCullough Peter McCullough is mentioned, aside from R. Kelly, G. Ruocco, and all these other names are here. 26 references, and each reference with quite a few names in it. So the details, I'd leave it up to you, because you don't have to open 10 papers. You just have to open maybe 3 or 2. I'd say open at least 2 or 3 so you can compare. Other than that, you don't have to go through a lot of references. Or you can also make your search more specific. Suppose I had entered early treatment for COVID-19 using hydroxychloroquine. The search would change. The results would change. If I had entered with the monoclonal antibodies, then the results would be specific to that. So, should we go through it one by one? Let's do it. So you have, of course, at the top, the names of those involved in authoring this information. And what does the abstract say? Let me enlarge the text. That is good. Excuse me. So, the abstract, what does it say? Misinformation and promotion of well-intended but disproved therapies for COVID-19 have plagued evidence-based shared decision-making throughout the COVID-19 pandemic. In times of crisis, clinicians may feel that their strong inclination to prescribe potentially harmful, unproven therapies on behalf of their patients is supported by beneficence. Clinicians should mindfully identify and avoid commission bias during this pandemic, especially as more data have accumulated to assist with clinically sound decision-making. And that is a very, very good beginning in the abstract. We describe a more evidence-based approach to treatment of early outpatient COVID-19, stressing the availability of Food and Drug Administration emergency use authorization therapies and considering plausibly beneficial non-prescription supplements that are generally regarded as safe. And all the keywords are here. Interesting to see melatonin is there among the keywords. Target audience, all physicians. Learning objectives. After completing the article, the learner should be able to 1. Identify evidence-based therapy for outpatient SARS-CoV-2 COVID-19 infection. 2. Identify non-prescription supplements generally regarded as safe for therapy of SARS-CoV-2 COVID-19 infection. 3. Define commission bias. Faculty credentials, disclosure, that's good. Accreditation, designation, ABIM, MOC. ABIM is the American Board of Internal Medicine's Maintenance of Certification, MOC program. Expiration date, July 1, 2023. So you can go through the article. I haven't gone through the article, of course, but I like from what the abstract says. That's just where you get the spirit of the article, not the matter of it, just the spirit of it. So evidence-based outpatient therapeutics. This is still a little bit philosophical at this point. And okay, good, they've given references. Okay, names of medicines are given here. The drug use, Sotrovimab and Imdivimab. That's the dosage used. Bamlanivimab, Etesivimab, zinc gluconicum, melatonin, vitamin D. Vitamin D is only at 2000 IU PO daily. Important immune modulator that it is. Melatonin mentions here is antioxidant and anti-inflammatory, decreased production found in the elderly. That is what I came across last night also in the other article about melatonin. Zinc gluconicum, what does that do? Documented antiviral activity. High doses would cause GI side effects or copper deficiency, and that is correct. So it has an effect on the gastrointestinal tract, aside from copper deficiency. Practically, you may not need to know the technical details about such things, because the end user, what he does is he needs to see the effect of taking what is prescribed. So they have divided in Table 2 the high-risk criteria required for bamlanivimab, etesivimab, or Sotrovimab, Imdivimab infusion. Group general population criteria has a BMI equal or greater than 35 kg. has chronic kidney disease, has diabetes, has immunosuppressive disease, is currently receiving immunosuppressive treatment, is equal or greater than 65 years of age. That's the general population. Wow. That's a very unhealthy general population. High risk criteria. Of course, high risk criteria. Cardiovascular disease, hypertension, chronic obstructive pulmonary disease, other chronic respiratory disease. 12 to 17 group. Just looking at this, you'll realize that when discussions on Twitter happen, people will talk about age group. That, people who are so young, what risk do they have from COVID-19? They should be the least worried about it. And of course, you expect younger people to be healthier, but then there's hardly ever a deeper analysis. It's not possible to do the deeper analysis on Twitter. It will take many tweets to get into deeper analysis. Or you could post a link with the research, and I would expect almost more than 95% of the people not to read the article in depth. But as you can see here, it mentions things like sickle cell disease, congenital or acquired heart disease, neurodevelopmental disorder, for example, cerebral palsy, medical-related technological dependence, tracheostomy, gastrostomy, or positive pressure ventilation, not related to COVID-19. And then others, asthma, reactive airway, or other chronic respiratory disease that requires daily medication for control. So we're talking about young people. And ideally we think of young people as healthy, but not in this segment of the population. Monoclonal antibodies should be given within 10 days of symptom onset to COVID-19 positive patients at high risk for disease progression. The criteria for utilization, logistical difficulty, and limited supply restricts this intervention's possible impact. So the authors are admitting that monoclonal antibodies, though advised, there are these difficulties. Criteria for utilization, logistical difficulty, limited supply. So that's where you get to see the reality on the ground when you read a paper like this, because the authors are familiar, not just because they have the credentials, but because they're working in an environment where they routinely come across these circumstances. So next line they say, however, with the number needed to treat of approximately 16 to 20, these medications may well reduce hospitalizations and lower the strain on medical facilities in areas that need relief. And there are two references. So 6 and 7. These two references are given, which refer to the papers and the scientists involved. Here is something. Let's read these. Let's read these 3 paragraphs, because they begin with hydroxychloroquine. This one begins with corticosteroid therapy. This one begins with ivermectin. Let's see. I think they are. Colchicine is also another one, which they have addressed here. Let's read these 3 paragraphs, and I want you to read the rest. I'm pretending that I'm not making a video, but I am, of course, very poor at pretending. I wouldn't be reading out loud if I was not making a video. That's one thing. Okay, so hydroxychloroquine or chloroquine alone or in combination with azithromycin is not recommended outside of clinical trial by the NIH, the Infectious Diseases Society of America, or the American College of Physicians for treatment of COVID-19. Hydroxychloroquine was studied in adults with early COVID-19, patients with mild to moderate COVID-19, and as post-exposure prophylaxis in randomized controlled trials, and was ineffective in all cases. And you have references here. Additionally, although QT prolongation is a potential concern from hydroxychloroquine, there are no clear guidelines for monitoring cardiac status in outpatients. For those who say it's absolutely harmless, or they don't want to look at the side effects or harms, they should read this. I do have a little bit of an irritation in my throat. I might drink some tea later on. For now, I'm just continuing with my cough and my reading. And I'm not even going to say excuse me every time I cough. So just please excuse me every time I cough. Corticosteroid therapy. I'm coming back to the paragraph here. Corticosteroid therapy is not currently recommended for use in the early outpatient setting. Current NIH guidelines list not using corticosteroid or dexamethasone as an A3 recommendation. I believe that's an A3. Couldn't be AII. I think it's an A and a Roman 3 recommendation. So this is the article from the NIH. Hypoxemic patients. Hypoxemic. Let's search that. Hypoxemic. Hypoxemia. Hypoxemia. An abnormally low amount of oxygen in the blood, the major consequence of respiratory failure when the lungs are no longer able to perform their chief function. Hypoxemic. Hypoxemic inpatients are typically treated with dexamethasone for a duration of 5 to 10 days. If patients are discharged prior to completion of corticosteroids, they may be sent home with oral corticosteroids. Okay. Then, ivermectin has gained popularity as a possible early outpatient therapy. To date, the therapy has not been listed as recommended by the NIH. Ivermectin was found to have effect on reducing or stopping viral replication in vivo, but concentrations need to obtain the in vitro IC50 are considerably higher than those achieved in human plasma and lung tissue. I've read this in so many references in different websites, all of which give reliable information. This is the language, this is what they say. The in vivo results and the in vitro differ, and this is the reason. The medication has been highly publicized as useful and effective in prevention and treatment of COVID-19 by the group Frontline COVID-19 Critical Care Alliance. However, a recent double-blind randomized trial including 478 patients showed no significant difference in time to resolution of symptoms in the ivermectin group versus placebo. A few small A few small trials in the United States and Europe compared ivermectin plus doxycycline to standard care. Standard care varied in each study involved vitamin B6, vitamin C, and hydroxychloroquine, or a combination of these medications. El-Ghazar et al. And Hashim et al. Reported decreased mortality with ivermectin-containing regimens. So honestly, they're giving you the findings. This is not the language that you hear from some of the doctors who vouch passionately for ivermectin. This language is a lot more objective and evidence-based. That is by itself an indication of what the author's mindset is, what they're trying to convey and how they're trying to convey it. So I can close this tab. Now the other one, I've already gone past 30 minutes, past 31 minutes. Early treatment for COVID-19 with SARS-CoV-2 neutralizing antibody, Sotrovimab. So Sotrovimab, and then it gives similar articles. A lot of collaboration here. Abstract, the background, methods. Let's just read the method. In this ongoing multi-center double-blind phase 3 trial, we randomly assigned in a 1:1 ratio non-hospitalized patients with symptomatic COVID-19 equal or more than 5 days after the onset of symptoms and at least one risk factor for disease progression to receive a single infusion of Sotrovimab at a dose of 500 mg or placebo. The primary efficacy outcome was hospitalization for less than 24 hours for any cause or death within 20 days after randomization. I hope I'm reading these signs correctly. I have my doubts. So I have to brush up on these symbols. Because when we were doing mathematics in school, we use these symbols, of course, greater than, less than, equal to. But the placement of the symbol is from so many years ago, and I haven't used these symbols in a long time. And I have my doubt I'm reading this correctly. I'll check on that. So I'm admitting that I need to brush up on my symbols. Let's read the conclusion. Among high-risk patients with mild to moderate COVID-19, Sotrovimab reduced the risk of disease progression. No safety signals were identified. Funded by Vir Biotechnology and GlaxoSmithKline. COMET-ICE clinicaltrials.gov number. The number is given. And from here, if you open the link, it should take you straight to that trial. And here it is. How nice. Sorry, and this was last update posted September 27, 2021, so it's not old at all. They're learning things all the time. I'll post a link for this as well. Good thing that I opened this. So every link I've opened, I'm going to post a link in the video description. This one, early treatment of COVID-19 patients with hydroxychloroquine and azithromycin, a retrospective analysis of 1,061 cases in Marseille, France. Excuse me. Let's just look at the result. A total of 1,061 patients were included in this analysis. 46.4% male, mean age 43.6 years, range 14 through 95 years. Good clinical outcome and virological cure was obtained in 973 patients within 10 days. Prolonged viral carriage was observed in 47 patients, 4.4%, and was associated to a higher viral load at diagnosis. But viral culture was negative at day 10. All but one were PCR cleared at day 15. A poor clinical outcome was observed for 46 patients, and 8 died, 74 through 95 years old. All deaths resulted from respiratory failure and not from cardiac toxicity. 5 patients are still hospitalized. 98.7% of patients cured so far. So, PCLID-O, poor clinical outcome, was associated with older age, severity of illness at admission, and low HCQ serum concentration. So all those factors. PCLID-O was independently associated with the use of selective beta-blocking agents and angiotensin II receptor blockers. A total of 2.3% of patients reported mild adverse events, gastrointestinal or skin symptoms, headache, insomnia, and transient blurred vision. Yes, I have read of these side effects, but when these side effects happen in a hospital, they always have the means for management. If there are severe side effects also, of course they would know how to manage them because there is supervision in a hospital. In outpatient cases, when medicines are prescribed, of course, then the question comes up of management of side effects. Also dosage. Will people take the recommended dosage or underdose or overdose themselves? All those things. Here, let me just read this part. I've tested positive for COVID-19, but I'm experiencing only mild symptoms. What will help me to recover at home? Let your doctor know that you have COVID-19. Some people who are at increased risk for severe COVID-19 illness may be candidates for oral antiviral treatment or intravenous monoclonal antibody therapy, both of which can reduce the risk of hospitalization and death. If you've been told to recover at home, these measures can help reduce symptoms. While you don't need to stay in bed, you should get plenty of rest. Stay well hydrated. To reduce fever and ease aches and pains, take acetaminophen or ibuprofen. Be sure to follow directions, of course, all the time. If you're taking any combination cold or flu medicine, keep track of all the ingredients and the doses. That is very important. When a lot of the problems arise when drugs interact. So drug interactions is a very major cause for complications. For acetaminophen, the total daily dose from all products should not exceed 3,000 milligrams. This is simple enough and clear enough. And this is better than how people prescribe over Twitter. So, another good article. Do I want to read this? I've read this before. I'm not going to read this. This is from the NIH. This I've also read. And why I scroll to the bottom right away is because I'm not going to read the whole article again. But what I'm going to read to you is what is mentioned at the bottom, it says WHO, NIAID Director Anthony S. Fauci, MD, is available to comment on this article. NIAID conducts and supports research at NIH throughout the United States and worldwide to study the causes of infectious and immune-mediated diseases and to develop better means of preventing, diagnosing, and treating these illnesses. News releases, fact sheets, and other NIAID-related materials are available on the NIAID website. And I'll leave a link for this article there, and the links on this page are, of course, for you to visit. But to say that early intervention is not considered, doesn't exist, is out of the thought process, I don't believe that. I don't think there are only a handful of good doctors who are conscious of early treatment, and other doctors are just doing nothing. I do not believe that. I think, yes, it's possible that there are doctors who, maybe many doctors, who are not doing as much as they should. But I also know a lot of doctors who are doing a lot more than we think they should. They burn themselves out, nurses and doctors. There are all kinds. This is an article I'd like for you to look at. Melatonin is inexpensive. Melatonin for the early treatment of COVID-19, a narrative review of current evidence and possible efficacy. Let's just look at the results. The results showed that melatonin acts to reduce reactive oxygen species mediated damage, cytokine-induced inflammation, and lymphopenia in viral disease similar to COVID-19. Conclusion: these conclusions provide evidence for potential benefits in melatonin use for COVID-19 treatments as early as the day of diagnosis. And how long? This is a long article, but I've looked at it not thoroughly. Let me read this conclusion here. Due to its demonstrated efficacy as an antioxidant, anti-inflammatory, and immunomodulator, the effects of melatonin can reduce the severity of symptoms and cellular damage induced by viral diseases. When started as an early treatment, the strategy melatonin offers is to slow the cytokine storm observed in COVID-19 and reduce the oxidative damage to enhance the resistance of individuals and provide additional survival time. With melatonin's high safety profile, abundance of availability, and low cost, the administration of 2.5 to 10 mg of melatonin at night should be initiated as soon as possible after diagnosis for all adult patients. Now, you know why this study is a good one. An additional reason is because it doesn't have money as the... just a moment, please. Yes, this study done on melatonin is not incentivized by money, by profit. Melatonin is inexpensive, and even if you find success, as they have seen potential benefit, a hospital or doctors don't stand to make money off finding the results, especially positive results. And it's more in the interest of the patient. So a study like this, are these studies conducted? Of course they're conducted. All studies are not for money. Of course, if you're looking for agents that cost hundreds or thousands of dollars, then the presence of money shows a lot of things. That the company spent a lot in the research of that drug, and probably took them, we don't know, 20 years, 30 years of research to developed that drug, and now they're enthusiastic that they can start with the phase 1 trial. They went through that, now they're at phase 2. The company has spent decades, and thousands of scientists might have worked on it, and they want it to succeed. So they have their own motivation. You know what? What if they decided, we don't want to be interested in this? We're just going to leave this and somebody else will do it. And nobody does it. Then what happens? That drug doesn't exist. But to work on something patiently for 20, 30 years, 40 years, and then for people to complain, oh, why are they thinking of earning money from it? They're making up for all that time also. That can happen. That does happen. And then when other companies are allowed to manufacture that drug after the patent rights have expired, then the prices come down. So all these things have a bearing. In the real world, they do. Early treatment for COVID-19 with SARS-CoV-2 neutralizing antibody, Sotrovimab. I am going to leave the link for this as well. There are 27 references and 5 citing articles. And when did this come out? It has a date, October 27, 2021. This article was published on October 27, 2021 at nejm.org. So, again, a lengthy article. A lot of this information would be more for professionals, especially if you go through the supplementary information, all these PDFs, 1, 2, 3, 4, 5 PDFs. And this is a 1.5 megabyte PDF. If you just look through the research summary, I guarantee it will be, if you're going to go through all the supplementary material, that itself will take a while. Let's take a look, in fact, since we're here. Why not? Here we go. That is one. Here's protocol. Protocol, that would be a longer document. It's taking a while to load. This page is working right now. That too happens. Let's try that one more time. Let's open it one more time. Protocol. Well, that's good. I'm doing everything live. There's no rehearsal. There's going to be no edits. And this page isn't working, but protocols generally, you could see for other drugs also in other companies also, that protocols are the more involved documents. And then this is the last of the pages, and I believe this is the simplest one. So, when did this come out? It doesn't have a date, but I do believe they keep on updating this information. Here, yeah, it last reviewed 19 January 2022. Next review due 2 February 2022. That is excellent. So they keep reviewing it, as they should. And they will update the page accordingly. I'm going to leave the link for this there as well. It has 2 types of COVID-19 treatment are available, Sotrovimab and Molnupiravir. Sotrovimab is a biological medicine. It is also known as a neutralizing monoclonal antibody. And MAB, molnupiravir, is an antiviral medicine. Don't tell that to people on Twitter. They already have a whole thesis in their mind of what molnupiravir is and supposed to do and what it is not and how much it should cost. And they wouldn't bother looking at molnupiravir from the official website. Nope, don't ask them to do that. Ask them to give opinions. They will do that aplenty. But don't ask them to do research. So now, how many tabs do I have open? Aside from the original search, I have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11 tabs, and 50 minutes have gone by. Not yet 1 hour. And this should demonstrate that if I spend 10 more minutes, which I'm not going to, because then what's left for you to do? Excuse me. If I spend 10 more minutes, I could go through this document very easily and go through its associated links. But what I'm not going to do is do what I just said I would. What I would rather do is just to mention what's on this page. I'm not navigating away from this page. So let's read this. People at highest risk. You may be at highest risk of getting seriously ill from COVID-19 if you have Down syndrome, sickle cell disease, HIV or AIDS, chronic kidney disease, CKD stage 4 or 5, certain types of cancer, had certain types of chemotherapy in the last 12 months, had radiotherapy in the last 6 months, had an organ transplant, a severe liver condition such as cirrhosis, a rare condition affecting the brain or nerves, multiple sclerosis, motor neuron disease, Huntington's disease, or myasthenia gravis, certain autoimmune or inflammatory conditions such as rheumatoid arthritis or inflammatory bowel disease. Now, that is a little surprising to me that IBD is also mentioned there. A condition or treatment that makes you more likely to get infections. A doctor or specialist will confirm if you're eligible for treatment. That should always be the case. And they also mention how is this list decided. Brief page, very to the point, and yet rich with information. COVID-19 treatments research. Antiviral medicines such as molnupiravir are also available through a national study run by the University of Oxford. The study is open to people in the UK who have tested positive for COVID-19 using a PCR test, have COVID-19 symptoms that started within the last 5 days, are aged 50 and over, or are aged 18 and over with a health condition that puts them at high risk of getting seriously ill from COVID-19. If you take part in the study, you may be randomly selected to receive the antiviral medicine. All right. How to get a COVID-19 treatment. All of this might sound very strange to people who think that COVID-19 is just some cough and a little fever and all that. I was one of those people who thought that's all it is. Just the symptoms, not the syndrome. As I mentioned in my video yesterday. So, I'm done. Going on 55 minutes, I'm done. And I'm going to close this video now. And I'm going to upload this to YouTube. It'll take a little while because it's almost an hour long. And I'll put all the links there in the sequence that I open them in every tab. And you're free to go through the document yourself, read the material, come to your own conclusions, find things that I haven't found. That's why it's written down, it's open. But let no one say information is not available. That claim is outdated. That's a claim from ignorance. So, thank you very much for your time, and I'll see you some other time in case I make a video. I don't make videos just for the sake of making videos. When I see a necessity, I might make a video maybe twice a day. If I don't see a necessity, I might not make one for a month. So that's me. Thank you for your time, and bye-bye.